The approval of Nivolumab for adjuvant melanoma really is a game changer in terms of the standard of care management of patients. So after surgery for high-risk stage 3 melanoma, historically there was quite an argument in the field about what the right thing to do was, with many physicians actually advocating that no intervention was the most appropriate treatment as opposed to giving interferons or interferon alpha 2b. We had the approval of Epilynium, which some considered to be an improvement and others advocated that patients should get it. However, the incidence of high-grade immune-related adverse events with Epilynium really limited its upside. So that really all changes now with the approval of Nivolumab, and really almost any patient who comes in with stage 3 melanoma really ought to be getting Nivolumab. The trial really encompassed sort of high-risk stage 3B, C, and 4 NED. That being said, with the shift in our surgical approach in melanoma to do less surgery, we're going to have actually fewer patients that meet that criteria and more that are really stage 3A, but you've got this inkling that they really look like they're probably higher stage patients. So really across the board in the adjuvant setting for immunotherapy, Nivolumab will become the standard of care. It is important to point out that we don't have any randomized head-to-head data for immunotherapy versus targeted therapy, because in the adjuvant space we also have approval of the BRAF and trametinib for BRAF mutant patients. So how do you pick between those two is still a huge argument, and that's the same argument we've had for metastatic disease now for a few years. Point being, however, is that those drugs that were highly successful for metastatic disease are now already translated into the adjuvant setting and makes these conversations with patients much different than it used to be in the past.